Hello everyone, now let us discuss about medical decision making, that is nothing but MDM. So what is MDM? Medical decision making is one of the key components of evaluation and management services. And medical decision making is the process by which a diagnosis or treatment plan is formulated from the available test information, often with incorporation of known patient preferences. Now coming to the key elements or components of MDM. So what are the governing factors by which the type of MDM can be determined are: the first is number and complexity of problems that are addressed during the encounter. Number and complexity of problems that are addressed during the encounter. The next is amount and complexity of data to be reviewed and analyzed. The next is the risk of complications, morbidity or mortality of patient management decisions made at the visit. Number and complexity of problems, amount and complexity of data to be reviewed, and finally the risk of complications, morbidity and mortality are the three key elements of medical decision making. Now coming to some of the documentation prerequisites. The documentation prerequisites of MDM. Documentation of MDM should contain a clear description of all problems managed, evaluated and or treated on the date of service, as well as severity and acuity of those problems. A description of the data ordered, reviewed or interpreted, plus any relevant analysis. For example, revised complete blood count from 1020 and an inserted analysis here. A description like this of any relevant analysis must be documented. If an assessment requiring an independent historian, for example, patient, spouse or guardian, assessment requiring an independent historian is obtained because the patient is unable to provide a complete or reliable history due to developmental stage or dementia or psychosis, even that should be documented that an independent historian has been used to acquire the information. Next is possible management options that were considered but ruled out after shared decision making while with the patient family. These considerations must also be documented. Any social determinants of health and their impact on the provider's ability to diagnose or treat the patient. This is also an important point. Any social determinants of health and their impact on the provider's ability to diagnose or treat the patient must also be documented. So these are some of the documentation prerequisites of MDM. Now let us discuss about social determinants of health with example. The first one is illiteracy and low level literacy. Low health literacy may require different or more extensive efforts with patient education. That is, the provider must put in more efforts in order to educate the patient regarding his condition. For example, physician may require to give all verbal instruction because the patient cannot read the written instructions. The next is inadequate housing. Some patients may have inadequate housing. So, patient may lack the refrigeration in their home. So, the physician cannot prescribe for cold storage medication. He need to prescribe something else. Or in some cases, patient may have mold infestation in their house. For that reason, physician need to intensify the management of their asthma. These are some of the examples for inadequate housing, which is a type of social determinant of health. The next is extreme poverty or low income. Because of the extreme poverty or low income, patient may not be able to afford the medication or other OTC type therapies or devices. For that reason, the physician cannot prescribe those drugs in the first place. And second is he needs to address them to some of the charity services. The next is disappearance and death of a family member. may decide to defer addressing some medical issues to prioritize providing emotional support for bereavement. Because of the death or disappearance of the family member, particular patient might require more emotional support than the immediate address to medical issues. For that reason, the physician need to refer them to social services and etc. So that is also an example of social determinant of health. The next is child in welfare custody. The child in welfare custody may have to spend extra time educating. The physician may have to spend the extra time educating new foster parent on medical management or how to provide support care for medical conditions because they are new to the child. So these are some of the examples of social determinants of health. And whenever any of the social determinants of health is there and the physician is putting in more efforts, in that cases you can increase the level of MDM. Now coming to the levels of MDM. The various levels of MDM are straightforward, low, moderate and high. MDM of straightforward MDM, MDM of low complexity, moderate complexity and high complexity. Now let us discuss about number and complexity of problems that are addressed during the encounter. Let us briefly discuss some of the definitions of what is minimal problem, what is limited problem, etc. Now coming to minimal problem, a problem that may not require the presence of a physician or other qualified healthcare professional, but the service is provided under the physician or qualified healthcare professional supervision, then that problem is considered as minimal problem. Now coming to self-limited or minor problem, a problem that runs a definite and prescribed course and is transient in nature and is not likely to permanently alter the health status of the patient. A problem that runs a definite and prescribed course and is transient or temporary in nature and is not likely to permanently alter the health status of the patient, then that problem is considered as self-limited or minor problem. Now coming to stable chronic illness. A problem with an expected duration of at least 1 year or until death of the patient is considered as chronic illness. And for the purpose of defining chronicity, conditions are treated as chronic whether or not stage or severity changes. For example, uncontrolled diabetes and controlled diabetes are a single chronic condition. Irrespective of the stage and severity of the condition, any condition that is expected with a duration of at least 1 year or until death is considered as a chronic illness. Now coming to stable. What is stable? Stable for the purpose of categorizing MDM is defined by the specific treatment goals for an individual patient. Stable is defined by the specific treatment goals for an individual patient. A patient who is not at his or her treatment goal is considered to be not stable. If treatment goal is not met, then the patient is considered to be not stable, even if the condition has not changed or there is no short-term threat to life or function. Let us see an example. For example, in a patient with persistently poorly controlled blood pressure, for whom better control is a goal, is not stable. Even if the pressures are not changing and the patient is asymptomatic, the risk of morbidity without treatment is significant. That is, the patient usually has persistently poorly controlled blood pressure. So here the treatment goal is controlled blood pressure. So here the treatment goals are not met. Hence the patient is considered to be not stable. Even the pressures are not changing and the patient is asymptomatic. Even at those high blood pressures also, patient does not have any symptoms. Even though he is asymptomatic and even the blood pressures are not changing, then also that scenario is considered to be unstable chronic illness. because here the risk of morbidity without treatment is significant. Examples may include well-controlled hypertension, non-insulin dependent diabetes, cataract, and benign prostate hyperplasia. Some of the examples of stable chronic illnesses include well-controlled hypertension, DM, cataract, or BPH. Now coming to next definition, acute and uncomplicated illness or injury. A recent or new short-term problem that is nothing but acute. Recent or new short-term problem with low risk of morbidity for which treatment is considered. There is little to no risk of mortality with treatment and full recovery without functional impairment is expected. A problem that is normally self-limited or minor but is not resolving consistent with a definite and prescribed course is an acute uncomplicated illness. For example, cystitis, allergic rhinitis, or simple sprain. A problem that is normally self-limited or minor but is not resolving consistent with a definite and prescribed course is considered as acute uncomplicated illness. Now coming to chronic illness with exacerbation, progression, or side effects of treatment. A chronic illness that is acutely worsening, poorly controlled, or progressing with an intent to control progression and requiring additional supportive care or requiring attention to treatment for side effects, but does not require consideration of hospital level of care. That is, admission is not required, but additional supportive care and attention are required for the treatment for side effects. That is considered as chronic illness with exacerbation, progression, or side effects of treatment. The next definition is undiagnosed new problem with uncertain prognosis. A problem in a differential diagnosis that represents a condition likely to result in a high risk morbidity without treatment. For example, limp in the breast. It is a new problem and it does not have a certain prognosis. Limp may be benign or malignant in that way. Next is acute illness with systemic symptoms. An illness that causes systemic symptoms and has a high risk of morbidity without treatment. For systemic, general symptoms include fever, body aches, or fatigue in minor illnesses that may be treated to elevate symptoms, shorten the course of illness, or to prevent complications. See the self-limited or minor problem or acute uncomplicated illness of injury. Systemic symptoms may not be general but may be of single system. Example are pyelonephrosis, pneumonitis, or colitis. So here acute illness with systemic symptoms. For systemic general symptoms such as fever, body aches, or fatigue in minor illnesses, they can be treated to alleviate the symptoms, shorten the course of illness, or to prevent the complications. And those problems are considered as self-limited or minor problems or acute uncomplicated illness. Systemic symptoms may not be general but may be of single system. For example, pyelonephritis, pneumonitis, or colitis. In these cases, it is considered to be a little more complicated than the minor or self-limited problem. Acute illness with systemic symptoms. The next is acute complicated injury. An injury that requires treatment that includes evaluation of body systems that are not directly part of the injured organ, and the injury is extensive or treatment options are multiple and or associated with risk of morbidity. An example is head injury with loss of consciousness. This is an example of acute uncomplicated injury. The next is chronic illness with severe exacerbation, progression, or side effects of treatment. The severe exacerbation or progression of chronic illness or severe side effects of treatment that have significant risk of morbidity and they require hospital level of care. Next is acute or chronic illness or injury that poses a threat to life or bodily function. An acute illness with the systemic symptoms or an acute complicated injury or a chronic illness or injury with exacerbation, progression or treatment of side effects. Side effects of treatment that poses a threat to life or bodily function in the near term without treatment. Examples may include acute myocardial infarction, pulmonary embolus, severe respiratory distress, progressive severe rheumatoid arthritis, psychiatric illness with potential threat to self or others, peritonitis, acute renal failure, or abrupt change in neurologic status. Now, as we have discussed the various definitions of different types of problems, let us calculate the complexity based on number and complexity of problems addressed in an encounter. So, for minimal complexity, the elements required according to number and complexity of problems are self-limited or minor problem, that is that runs a prescribed course and is transient in nature and is not likely to permanently alter the health status. So whenever there is self-limited or minor problem, the complexity according to number of diagnosis is minimum. Second case is when the complexity will be low. Whenever there are two or more self-limited or minor problems, or when there is one stable chronic illness, for example, well-controlled hypertension, diabetes, cataract and BPH, or when there is one acute uncomplicated injury or illness, for example, cystitis, allergic rhinitis or a simple sprain. In all these cases, the complexity is low. Now let us discuss about moderate complexity. Whenever there is one or more chronic illnesses with exacerbation, progression or side effects of treatment that require supportive care of attention to side effects but not hospitalization. The next is two or more stable chronic illnesses. Whenever there are two or more stable chronic illnesses, the complexity will become moderate. When there is one undiagnosed new problem with uncertain prognosis. For example, lump in the breast as we have discussed earlier, that goes to moderate complexity. The next is one acute illness with systemic symptoms. For example, pyelonephritis, pneumonitis or colitis. This also leads to moderate complexity. The next is one acute complicated injury. That is head injury with brief loss of consciousness, leads to moderate complexity. Now coming to high complexity. When one or more chronic illnesses with severe exacerbation, not simply exacerbation, severe exacerbation, progression or side effects of treatment, significant risk of which lead to significant risk of morbidity and they may require hospitalization. Whenever hospitalization is required to treat the side effects of treatment, that goes to high complexity. Next is one acute or chronic illness or injury that poses a threat to life or bodily functions. Example, acute myocardial infarction, pulmonary embolus, severe respiratory distress, progressive rheumatoid arthritis, psychiatric illness with potential threat to self or others, and peritonitis. The next is acute renal failure or any abrupt change in neurological status. All these problems, they lead to high complexity. By this we complete the number and complexity of problems addressed at the encounter and the various scenarios which lead to minimum, low, moderate and high complexities. Now coming to amount and complexity of data to be reviewed or analyzed. Let us see some of the definitions regarding the data. External. What does external indicate? External records, communication and or test results are from an external physician or other qualified healthcare professional, facility, or healthcare organization. Next definition is external physician or other qualified healthcare professional. An external physician or other qualified healthcare professional who is not in the same group practice or is of different specialty or subspecialty is considered as an external physician. This includes licensed professionals who are practicing independently. The individual may also be a facility or organizational provider, such as from a hospital, nursing facility, or home health care agencies. Coming to the term discussion, what does discussion indicate? Discussion requires an interactive exchange. The exchange must be direct and not through intermediates. For example, clinical staff or trainees. The discussion must be between the two physicians regarding the patient condition. Sending chat notes or written exchanges that are within progress notes does not qualify. Sending chat notes or written exchanges that are within the progress notes does not qualify as an interactive exchange. The discussion does not need to be on the date of encounter, but it is counted only once and only when it is used in the decision making of the encounter. It may be asynchronous, that is, it does not need to be in person, but it must be initiated and completed within a short period of time, that is within day or two. So whenever there will be a discussion between the two physicians, a primary care physician and a specialization physician, for example, regarding the decision for the treatment of patient, then that is considered as discussion. Simple chat notes or written exchanges that are within the progress note does not qualify as an interactive exchange. And similarly, exchange must be direct and not through intermediates, that is clinical staff or trainees. And it need not be on the same day, and it may be asynchronous, that is it need not be in person, but it must be initiated and completed within a short period of time. Now coming to test. Tests are imaging, laboratory or psychometric or psychological data. A clinical laboratory panel, for example, basic metabolic panel, is a single test. The differentiation between single or multiple tests is defined in accordance with the CPT code set. For the purpose of data reviewed and analyzed, pulse oximetry is not a test. For the purpose of data reviewed and analyzed, pulse oximetry is not a test. The next is unique. What does unique indicate? A unique test is defined by the CPT code set. When multiple results of the same unique test, for example, serial blood glucose values are compared during an E&M service, you need to count it as one unique test. Tests that have overlapping elements are not unique. Tests that have overlapping elements are not unique even they are identified with distinct codes. For example, a complete blood pressure or blood count CBC with differential would incorporate the set of hemoglobin, CBC without differential, and platelet count. Here you need not count as three tests: hemoglobin, CBC without differential, and platelet count. All these things are included in the CBC with differential test. A unique source is defined as a physician or other qualified healthcare professional in a distinct group or different specialty or subspecialty or unique entry. Review of all materials from any unique source count as element towards MDM. Review of all materials from any unique source. What is unique source? Unique source is defined as a physician or other qualified healthcare professional in a distinct group or different specialty or subspecialty or a unique entry. So the review of all materials from any unique source counts as one element towards MDM. Now coming to independent historian, an individual, example might be a parent, guardian, surrogate, spouse or witness, who provides a history in addition to history provided by the patient, who is unable to provide a complete or reliable history due to his developmental stage, dementia or psychosis, or because of a confirmatory history is judged to be necessary. In the case where there may be conflict or poor communication between multiple historians, more than one historian is needed. The independent historian requirement is met. Independent history does not need to be obtained in person, but does need to be obtained directly from the historian providing the independent information. Independent historian may be an individual who might be a parent, guardian, surrogate, spouse or witness who provides a history in addition to history provided by the patient, who is unable to provide a complete or reliable history. Reason might be due to developmental stage or dementia or psychosis. The next is independent interpretation. Interpretation is assessment or analyzing. So the interpretation of a test for which there is CPT and an interpretation or report is customary. For a test which have a specific CPT code, an interpretation or report is customary. This does not apply when the physician or other healthcare professional is reporting the service or have previously reported the service for the patient. A form of interpretation should be documented but need not conform to original standards of complete report for the test. In some cases, the attending physician may do independent interpretation. Independent interpretation is considered only when the physician or other qualified healthcare professional is not reporting the service or they have not reported the service for the patient. In those cases, only independent interpretation can be considered. And a form of interpretation should be documented, but it need not confirm to be of usual standards. That is, a cardiologist or a small orthopedic surgeon, he need not write an interpretation report as that of a radiologist, but he might have done certain interpretation and he might have written some of the clinical notes. So those clinical notes can be considered as independent interpretation because those clinical points does not usually come in alignment with the standards of a complete radiological report for the test. Now that we have discussed the various definitions regarding the amount and complexity of data to be reviewed and analyzed, let us discuss the categories which govern the type of amount of data and complexity to be reviewed. So the amount and complexity of data to be reviewed is categorized into three categories: category 1, category 2 and category 3. So what points are included in the category 1? Category 1 includes review of prior external notes from each unique source. Review of prior external notes from each unique source. Next is review of the results of each unique test. The next is ordering of each unique test. Ordering of test includes the review of results. The next is assessment requiring an independent historian. It has 4 elements. All these 4 elements, they contribute to category 1. Next, coming to category 2. Category 2 includes independent interpretation of test performed by another physician or qualified healthcare professional, not separately reported. The next category 3. It includes discussion of management or test interpretation with external physician or other qualified healthcare professional or appropriate source, not separately reported. Now coming to the complexity of minimal, limited, moderate and extensive. Based on the amount and complexity of data to be reviewed and analyzed, complexity can be minimal, limited, moderate, or extensive. So when the complexity according to amount of data to be reviewed is minimal, whenever there is no or minimal or no data, in that case the complexity is minimal. That is, whenever there is no data to review or very minimal data is available to review, then risk factor or the complexity here is minimal. Next is limited. Meet category 1 as stated below. In order to be qualified as limited complexity, any data assessment should meet category 1 as stated below. It should meet any combination of 2 from items 1 to 3 or meet 4, that is independent historian. In simple words, in a medical decision making, whenever an independent historian is used for determining history of a patient, the complexity according to amount of data to be reviewed goes to limited. Whenever independent historian use or when 2 from items 1 to 3 are met. There are 4 elements in category 1. In those 4, either 4th element is met or from 1 to 3 any 2 points are met. In all these cases, the complexity is considered to be limited. So when will complexity is considered to be moderate according to amount of data to be reviewed? Meet one of 3 categories as below. They have a specific guideline. Coming to category 1, should meet any combination of 3 from items 1 to 4. In order to be qualified of moderate complexity, any of the 3 elements must be met from 1 to 4 in category 1, or category 2 must be met, or category 3 must be met. Category 2 is independent interpretation of test. Category 3 is discussion and management of test interpretation external. So if any of the above, either category 3 or category 2 or category 1 are met, category 1 should require 3 from items 1 to 4. In all these cases, moderate complexity can be assessed for amount of data. Now coming to extensive complexity. Should meet 2 out of 3 categories as below. Here any one of the, if the assessment meets any one of the category, that is sufficient for moderate. In order to be extensive, should meet 2 of 3 categories as below. Category 1 should meet any combination of 3 from items 1 to 4. The next is category 2 and category 3. In simple words, in order to be called as extensive complexity, the patient must have undergone independent interpretation and discussion of test management, or the patient must have undergone independent interpretation and the category 1, 3 elements of category 1 are met. So 2 points should meet, 2 categories should meet in order to be called as extensive. But only 1 category is necessary in order to be called as moderate. By this we complete the amount and complexity of data to be reviewed and analyzed. Now coming to risk of complications, morbidity or mortality of patient management decisions made at the visit. In simple words, risk of morbidity or mortality. Now coming to the definition of risk, the probability and or consequence of an event. The probability and or consequence of an event is considered as risk. The assessment of level of risk is affected by the nature of the event under consideration. For example, a low probability of death. Here, the probability of death is there, but it is low. It may be considered as high risk, whereas a high chances of a minor self-limited adverse effect of treatment may be of low risk. because this is a self-limited problem. Here there is no probability of death. Even though there is low probability of death, then it is considered as a high risk, whereas a high chance of minor or self-limited adverse effect of treatment may be of low risk. The definitions of risks are based upon the usual behavior and thought process of the physician or other qualified healthcare professional in the same specialty. For the purpose of MDM, level of risk is based upon consequences of the problem addressed at the encounter when appropriately treated. The risk also includes MDM related to need to initiate or forego further testing, treatment or any hospitalization. Risk is based upon the consequences of problem addressed. Consequences. What are the consequences of treatment of a particular problem? That is the risk. It is also related to need to initiate or forego further testing, the treatment or hospitalization. The risk of a patient management criteria applies to patient management decision made by reporting physician or qualified healthcare professional as a part of reported encounter. In simple words, risk is nothing but the consequences of the treatment, consequences of a particular diagnosis, and consequences and the probability of the consequences that occur from the treatment. Now coming to morbidity, a state of illness or functional impairment that is expected to be substantial, that is expected to be of substantial duration during which function is limited, quality of life is impaired, or there is organ damage that may not be transient despite the treatment. That is considered as morbidity. In simple words, functional impairment or a state of illness that will affect the quality of life, or it can damage the organ permanently despite the treatment. That is defined as morbidity. Next are social determinants of health, that are nothing but economic and social conditions that influence the health of people and communities. For example, food and housing insecurities. Coming to surgery, major or minor, elective or emergency, procedural or patient risk. Coming to minor surgery or major surgery. The classification of surgery into minor or major is based on a common meaning of such terms when used by trained clinicians, similar to the use of term risk. These terms are not defined by surgical package classification. Coming to surgery, elective or emergency. Elective procedures are emergent or urgent procedures. Describe the timing of a procedure when the timing is related to patient's condition. An elective procedure is typically planned in advance. Elective means planned in advance, that is scheduled for weeks later, while an emergency procedure is typically performed immediately or within minimal delay to allow the patient stabilization. Both elective and emergent procedures may be minor or major procedures. Now coming to surgery risk factors, patient or procedure. Risk factors are those that are relevant to a patient or a particular procedure. In some cases, patient might have risk factors. In some cases, that particular procedure might have risk factors. Evidence-based risk calculations may be used but are not required in assessing patient or procedural risk. Coming to drug therapy requiring intensive monitoring for toxicity. A drug that requires intensive monitoring is a therapeutic agent that has a potential to cause serious morbidity or death. Drugs which cause serious morbidity or death, they require intensive monitoring for toxicity. The monitoring is performed for the assessment of these adverse effects and not primarily for the assessment of therapeutic efficacy. This is an important point. Here, the monitoring is performed for the assessment of adverse effect, but not for the assessment of therapeutic efficacy. That is how good the drug is not measured here. What are the adverse effects? Those are monitored in the toxicity monitoring. Monitoring should be that which is generally accepted practice for an agent but may be patient specific in some cases. Intensive monitoring may be of long term or short term. Long term intensive monitoring is not performed less than quarterly. The monitoring may be performed with a laboratory test, a physiological test, or imaging. Monitoring by history or examination does not qualify. The monitoring affects the level of MDM in an encounter which is to be considered in the management of the patient. So examples may include monitoring of cytopenia in the use of anti-neoplastic agent between dose cycles or short-term intensive monitoring of electrolytes or renal function in patients who are undergoing diuresis. Coming to examples of monitorings that do not qualify include monitoring of glucose level during insulin therapy, as the primary reason is the therapeutic effect. Unless severe hypoglycemia is current or of significant concern, or annual electrolytes or renal functions for patient on diuretics, as frequency does not meet the threshold. So here are the examples where drug therapy monitoring is considered as intensive monitoring for toxicity. And some of the examples which does not qualify for intensive monitoring for toxicity. Now that we have discussed the definitions, let us calculate the risk of complications and morbidity in determining the complexity. So according to risk of morbidity and mortality, what is minimal complexity? That is minimal risk of morbidity from additional diagnostic testing or treatment. For example, rest, gargles, elastic bandages, superficial dressing. All these treatment management will qualify for minimal complexity. Now coming to low complexity, low risk of morbidity from additional diagnostic testing or treatment. Example includes OTC drugs, minor surgery with no identified risk factors, physical or occupational therapy. All these management options, they lead to low complexity according to risk of morbidity and mortality. Coming to moderate complexity, examples include only prescription drug management, decision regarding minor surgery with identified patient or procedure risk factors, decision regarding elective major surgery without identified patient or procedure risk factors. Next point is diagnosis or treatment significantly limited by social determinants of health. All these management options lead to moderate complexity. The next is high. Examples are drug therapy requiring intensive monitoring for toxicity. It leads to high complexity, and decision regarding elective major surgery with identified patient or procedure risk factors. The next is decision regarding emergency major surgery. The next is decision regarding hospitalization, decision not to resuscitate or to de-escalate care because of poor prognosis. All these management options, that is patient assessment, leads to high complexity. By this, we complete the risk of complications of and/or morbidity or mortality. Now let us come to step 4. So the first 3 steps are first determining the complexity based on number of diagnoses. The next is determining complexity based on amount of data to be reviewed. The third step is determining the complexity based on risk of morbidity and mortality. Fourth step is you have to group together all these 3 elements and then you need to calculate the level of MDM. Now let us discuss step 4. So according to number of complexity and number and complexity of problems addressed. Here level minimal. The next is amount and complexity of data to be reviewed, even when it is minimal. And the next are risk and complications of morbidity and mortality, which have minimal risk. So minimal in all these 3 points. That is, number and complexity of problems addressed should be minimal. Amount and complexity of data to be reviewed should be minimal, and risk of complications of morbidity or mortality of patient management should be minimal. All these, when all these are minimal, it leads to straightforward MDM. And the next is example of straightforward MDM are 99202, which is a new patient code of office outpatient. The next is 99212, which is an established patient code for office outpatient services. This we will discuss in the next session. Next is low complexity based on number and complexity of problems addressed, limited amount of data reviewed, and low risk of morbidity and mortality. All these three, they lead to low MDM, which is given by 99203 and 99213. 203 for new patient and 213 for established patient. Here we are taking the examples of outpatient services, OP services. The next is whenever the risk or complexity is moderate according to number and complexity of problems. Next is amount of data to be reviewed is moderate. Next is risk of complications of mortality and morbidity is moderate. When all three are moderate, it leads to moderate MDM. When number of problems to be addressed and complexity is high, whenever there is extensive data to be reviewed, whenever there is high risk of morbidity and mortality, all these three elements, they lead to high MDM, which is given by the codes 99205 and 99215. By this, we complete the medical decision making. In the next session, we will be focusing on the outpatient services. Thank you for watching. Please subscribe for further videos on medical coding and CPC training.